everyone to this amazing symposium. My name is Tracy Green, and I'm the Deputy Director of the COBRE on Opioids and Overdose in Rhode Island. And welcome to the 2021 Substance Use Research Symposium. We have a number of days of exciting keynote speakers and research showcases from around the country. I'd love to share with you that we have been joined, and this event is co-hosted by a number of organizations: the Rural Drug Addiction Research, RDAR COBRE, the COBRE on Opioids and Overdose in Rhode Island at Rhode Island Hospital, the West Virginia Clinical and Translational Science Institute, the West Virginia INBRE at Marshall University, and the COBRE Center for Addiction and Disease Risk Exacerbation, or the Coderre, at Brown University. We all together are coming to talk and bring the brightest of minds and thoughts to share and exchange around this symposium. So I'm going to touch upon a couple highlights. You'll soon be hearing from our keynote speaker, Tom Coderre. Tomorrow, tune in for the keynote from Colleen Hanlon, who's a professor at the Department of Cancer Biology and at the Center for Substance Use and Addiction at Wake Forest School of Medicine. On Thursday, we'll have a keynote from Dr. Ali Rezai, the Executive Chair and Vice President and Associate Dean of the J.W. Ruby Memorial Hospital at West Virginia University's Rockefeller Neuroscience Institute. And then we'll have a closing keynote on Friday from Dr. William Stoops, who's a professor at the Department of Behavioral Science, Psychiatry, and Psychology at the University of Kentucky. There will be Q&A sessions and discussion after each of these amazing leaders and thinkers. So please join and bring your questions and inspiring discussions. To kick us off, I'd like to welcome Tom Coderre. Tom is a Rhode Island treasure with decades of public, private, and nonprofit service. Tom is the first person in recovery to lead SAMHSA. His career has been significantly influenced by his personal journey and philosophy, and we'll hear more about many of the things he's brought to the office at SAMHSA. He's well known in the addiction recovery community and joined SAMHSA as a senior advisor to the administrator in August of 2014. He's now the acting assistant secretary for mental health and substance use at SAMHSA after being appointed by President Biden to lead the agency in the interim earlier this year. From 2016 to 2019, he served as a senior advisor to the Rhode Island governor, Gina Raimondo, in which capacity he was the liaison to the General Assembly and coordinated our state's response to the opioid crisis. That's where I spent a lot of time with Tom and Jody, who leads, Jody Rich, who leads the COBRE on Opioids and Overdose, and I co-wrote the strategic plan and worked very closely with Tom in implementing it. He's the former chief of staff to the Senate president in Rhode Island, former national director, field director of the Faces and Voices of Recovery, and former board chair of Rhode Island's own statewide recovery community organization, RICARES. Tom's also served as a member of the Rhode Island Senate from 1995 to 2003, and he's a graduate of Rhode Island College. He works on a variety of issues at SAMHSA, and you'll be hearing about some amazing initiatives where he's taking the lead. Please welcome Tom Coderre as our keynote today.
Good morning, Tracy, and thanks so much for that kind introduction. We're going right into the keynote right now.
I think, let's see, small transition maybe as you grab your slides, but and
yeah,
grab a cup of coffee if you'd like, or water for those who are joining.
Wonderful. So it's a real honor and a privilege for me to be able to join you, Tracy, and your colleagues with the COBRE and all the organizations that are partnering on today's event. It's so great to see everyone coming together, in such an impactful way to solve one of our most pressing issues in this country, and that's of overdose, right? The overdose crisis that we're in the middle of. And I'm going to talk a little bit about the federal efforts and where we're leaning in to try to be part of the solution. But before I do, I'd love to just share a short story with you, if that's okay. This story is about a man who, by the time he was 30 years old, was pretty successful by most people's standards. He came from a good, loving family, and he had many friends. He was employed in nonprofit management and development for many years, and he had risen in his career to become the executive director of a large nonprofit agency. He was also very involved in his community, and he had a love of politics, and he got elected to the state Senate when he was 25 years old. So on the outside, as you can see, everything about this man's life looked normal, and some would even say perfect. However, on the inside, he was tortured. So he turned first to alcohol and then to other drugs to cope with the stresses that he was experiencing. Underestimating the power of these substances and not understanding the neurological consequences of taking them, he quickly became addicted. And his life, well, you know what happened to his life. It started this downward spiral. As his life began to unravel, he started to lose the things that were most important to him. When his family and friends tried to help, he resisted their help and he pushed them away. This caused him to lose them. He lost interest in politics. He lost his job and his position in the Senate. His health deteriorated. In the end, he lost everything, even his desire to live. This man's life, which at one time was so full of hope, became hopeless pretty quickly. And as some of you may have guessed, I know this story well because it's my own. But fortunately, the story does not end there. I was able to get the help that I needed. And today, I'm a person in long-term recovery, which for me means I haven't used alcohol or other drugs since May 15th of 2003. So over this 18 years, I have had this incredible opportunity to heal, to experience, and to rebuild my life. And my life has gotten a whole lot better over that time. In fact, being in recovery hasn't just enabled me to create a better life for myself, but it's also enabled me to create a better life for my family and ultimately for my entire community. Because that's what happens when we help people find and sustain their recovery. Everything around them changes. And we know that recovery is much more than just not using alcohol and other drugs. It's about creating a better life. It's that process of change, right, that we talk about, that people go through. You know, one of the things that I am incredibly grateful for is the fact that I had access to psychiatric services and long-term intensive substance use disorder treatment. That should be available to anyone who needs it. You know, I was lucky to have spent 6 months in a long-term residential facility. And then for me, the transition from treatment to sustained recovery was marked by my acceptance into a recovery house where my journey continued. You know, I am forever grateful for that option and that opportunity that I had, that privilege that I had. For my recovery home played an irreplaceable role in my personal story of recovery. We know that a person with safe, knowledgeable, supportive, and accepting home environments, they're better poised to secure stable employment, to pursue education and job training, to maintain recovery, and ultimately be able to give back and build up a reserve of recovery capital that contributes to the well-being of every member of their community. You know, SAMHSA calls this health, home, purpose, and community, the 4 major dimensions that support a life in recovery. Make no mistake about it, I was a badly broken human being just 18 years ago. And my road through treatment to recovery, it's been long and it's been winding. And even with the services that I was fortunate to receive, you know, no one waved some magic wand and I instantly became well. It happened over time, not overnight. And it happened because I had support. I know that you understand, many of you on this call, you work in the trenches every day, and you understand the hard work that's required to complete treatment and to sustain recovery. And you also know the vital role that peer support plays in that process. You know, there are many pathways to recovery, 12 steps, mutual support, medication assisted, faith-based, fitness-oriented, smart recovery, natural recovery. Some people just wake up one day and decided they've had enough. And it's not really important how somebody gets into recovery. It's more important that they do. Their pathway is not as important either. It's that they don't path alone, that they have help and they have somebody to walk on that journey with them. So for me personally, peer support was essential for my recovery. Peer support taught me that I was not alone. Peer support taught me that treatment is effective and that people can and do recover. It provided me that hope, community, a belief in today, and a faith in tomorrow. Peer support also provided this resilient and robust infrastructure of people and places, and peer support provided this loving but rigorous cohort of reinforcers. The people who understood the pitfalls, the daily struggles, the doubts, the uncertainties, the rationalizations, and who, passing no judgment, they didn't waver in pointing the way forward for me. These peers are people that a power much greater than myself brought into my life to give meaning and purpose to my life and to set me on a path where I too would be able to have the chance to help others in need. After living as a resident in that recovery house for 6 months, I eventually became the assistant house manager and then the house manager. And for almost 3 years, I called it my home. While living there, I went back to school and I finished my bachelor's degree. I was 9 credits short of a bachelor's degree. I had this habit in my active addiction of starting things and not finishing them. I also was able to obtain employment outside of the recovery house, employment that bolstered my confidence and encouraged me to take the next steps on my journey. During this early phase of my recovery, I established a recovery regimen that sustains me to this day. I continued seeing a medical doctor and participating in outpatient counseling and therapy. I started taking care of myself physically as well as mentally. I attended 12-step fellowship meetings and I started to socialize with other people in recovery. So today, through treatment, recovery, and hard work, I am once again an active and productive member of my community. And I've been able to regain the things that in my life that are the most important to me. When rebuilding my career eventually became a priority, I'm forever grateful to the folks at the ATTC at Brown University who looked beyond my health history and gave me the opportunity to restart my professional career. My friend Steve Gumbley and Sue Storty, who asked me to help them do training coordination at the ATTC. Imagine the disbelief in my eyes when I received an employee ID from an Ivy League institution that said faculty and staff on it. When I had 3.5 years in recovery, I went to work at Faces and Voices of Recovery in Washington as their national field director, as Tracy mentioned. In that position, I traveled around the country for 2 years, about 245 days each year, working with recovery community organizations to help build a constituency of consequence that would stand up and speak out. Then I was able to go back to the state Senate in Rhode Island, where I once served, and become the chief of staff to the Senate president, a job I held for 6 legislative sessions. You can imagine what a personal milestone that was for me. This is really where I first saw my life come full circle in recovery. And in 2014, I was appointed by President Obama as a senior advisor to the administrator at SAMHSA. And working at SAMHSA gave me the opportunity to participate more directly in the federal administration to advance publicly supported prevention, treatment, and recovery programs. After that, I returned to the Rhode Island State House, but this time as a senior advisor to the governor. And as Tracy mentioned, I got to help coordinate the state's response to the opioid crisis and to work on mental health and addiction issues more broadly. In 2019, I returned to SAMHSA as the regional administrator for Region 1 in New England. And then on January 20th of this year, the Biden-Harris administration asked me to be the acting assistant secretary. And then Dr. Delphin Rittman was appointed, and I slid over into the acting deputy assistant secretary role, where I'm helping her transition into her new job, and I'll remain there as long as I'm needed. So in all of this, I've been very, very fortunate in my professional life to have worked both in the public and private spheres, to count as colleagues and friends, grassroots organizers, frontline workers, and public policymakers, and to be able to see the world through their eyes, to gain the benefit of their perspective, their expertise, and their lived experience. And that's really guided me. So you can see peer support continues to carry me through the day. Whenever I have a crisis of confidence, and that happens frequently when I don't know how to do something or what the answer might be, I can reach out to friends like Tracy or Jody or others on this call, and we can brainstorm solutions. Throughout my journey, I've also been very fortunate to have incredible support from my family. That family that I say I resisted their help and pushed them away, they're back in my life and I'm back in their life. I have 6 nieces and nephews, my brother and my sister, my parents. I lost my dad 2 years ago, but he got to see his son in recovery for 16 years, and that was an amazing gift. Today I have stability, I feel great, and I'm active in the things I love: family, friends, community, service, policy, politics. And I have relationships with people that are so much deeper, stronger, and meaningful than anything I had prior to finding recovery. So these are also the gifts. And I want to acknowledge that my story of recovery, my story of rebirth, redemption, or whatever you want to refer to it as, is not unique. It's important and it's special to me, but it's not unique. It's the story of more than 25 million Americans. It's my story, and maybe it's some of yours on this call today. And while we've made progress, the hard truth is that there's just as many people that are struggling as we gather here this morning. And I am constantly in pursuit to help them find what I've found. And I know you all are too. So it's an honor being here this morning. It's an honor to be able to share my story with you. And now I have a few slides that I want to share with you where I can just talk a little bit about the federal response to the crisis that we're in the middle of. But thank you for bearing with me and allowing me to share some of my personal experiences first. Let me see, I'll go to my slides here. Great, so hopefully folks can see these all right, and I will start the slideshow in the beginning. I would assume somebody would tell me if they can't see these, so I will just assume they're showing up fine for you guys. So at SAMHSA, we're good. Thank you, Tracy. We are concerned with behavioral health, which of course is a national priority. And our mission is to reduce the impact of substance use and mental illness on America's community. Many of you know us for our grant making, and clearly I'm going to talk about our grant making today, and that's super important. But we also are concerned with leadership, providing leadership to the field, voice, data, surveillance, public education, regulation and standard setting, and practice improvement. We believe that behavioral health is essential to health. You can't have one without the other. Prevention works, intervention is important, treatment is effective, and people can and do recover. I mentioned Dr. Delphin Rittman, who is our new Assistant Secretary for Mental Health and Substance Use. She has outlined 5 immediate priorities: preventing overdose, enhancing access to suicide prevention and crisis care, promoting children and youth behavioral health, integrating, and we've heard this for a long time, but we're really trying to do something about this, integrating primary and behavioral health care, using performance measures, data, and evaluation. Those are her 5 near-term priorities. And she's also identified 4 cross-cutting principles that underpin all of those priorities: equity, workforce, financing, and recovery. So this is kind of what we're focused on, and this is our roadmap. And it aligns with the new administration, the Biden-Harris administration's priorities. And we are trying to make sure that we are integrated as much as possible with those new priorities. Many of you know that HHS Secretary Javier Becerra just announced and unveiled HHS's overdose prevention strategy. And I wanted to take a few minutes to talk about it here this morning. It's no surprise to anybody on the call that the overdose crisis is really worsening, and it's largely driven by synthetic opioids, predominantly illicitly manufactured fentanyl. Drug overdoses involving psychostimulants, such as methamphetamine, are also increasing, both with and without synthetic opioid involvement. The provisional trends, this is data on this slide from 2019, because that's the last official data we have from CDC. We should be seeing the 2020 data soon, but the provisional data suggests that overdoses are increasing for psychostimulants and cocaine. For the period ending December 2020, we know that we have more than 93,000 predicted overdoses, increases in all but 2 jurisdictions. The only jurisdictions that didn't see increases were New Hampshire and South Dakota. All opioids saw a 37% increase. Synthetics saw a 54% increase. Psychostimulants saw a 46% increase. Cocaine saw a 21% increase. And the trends were worsening during COVID, despite our best efforts, despite introducing flexibilities, increasing the amount of medications, treatment, and other types of supports available to people. So that's the reason why we're here talking this morning. That's the reason why Secretary Becerra released this new strategy. And I just wanted to share a few highlights of the strategy with you. Given the changing face of the crisis and the escalating harms, including during the COVID-19 pandemic, Secretary Becerra released this new strategy. It's comprehensive, it's resourced, and it's really to strengthen our primary prevention efforts and increase access to the full continuum of care and services for individuals with substance use disorders and their families. The strategy reflects the Biden-Harris administration principles of equity for all underserved populations and evidence-based policy by being more inclusive of all populations affected. And we're, also these priorities are translating research into equitable practice. And we're trying to identify ways to further our understanding of how to mitigate overdose harms. The strategy recognizes that addressing the overdose crisis requires a multifaceted and integrated approach spanning public health, healthcare, human services, and many, many other sectors. So we're moving away from talking about this as an opioid crisis and talking more about really identifying the root causes of overdose, because as we know, it's moved way, way beyond opioids at this point. Experts across HHS came together to leverage the best evidence to prioritize 4 key target areas for the strategy: primary prevention, harm reduction, evidence-based treatment, and recovery support. Within each of the priority areas, the strategy lays out 4 objectives with associated activities. There's 44 activities in total. So these high impact featured activities are not exhaustive of all the HHS activities in this space or that are underway to address overdose, but they are a good sampling of those. Additional activities are going to be added over time, and outcomes associated with each activity are going to be measured regularly to assess the progress, and so we can make changes as we see necessary. There are 4 cross-cutting principles that are guiding this entire strategy. Equity, maximizing health equity for underserved populations is definitely one of our strategy focuses. Activities aim to provide culturally competent care and address underlying social determinants of health. The strategy objectives and activities are informed by the best available evidence and data is going to be used to measure, monitor, and track the patterns and trends. Public health surveillance, data, research, and evaluation are going to be critical components to each of the priority areas. The strategy aims to break down barriers that silo substance use disorder services from other types of healthcare and social services, and to promote integrated care. And healthcare systems, social and self-stigma really impede access to substance use disorder services. We all know that. The strategy activities aim to reduce false perceptions about SUD and people who use drugs for that matter. Let's look at each of the priority areas in a little bit more focus. Preventing substance use and substance use disorders is critical to reducing overdose deaths. This priority area supports population level and individual level multidisciplinary substance use disorder prevention activities that are necessary to address the biological, behavioral, social, and environmental risk and protective factors. We have 4 objectives, as you can see here, to support research and surveillance, to develop and improve delivery of prevention interventions, facilitate the implementation of evidence-based primary prevention across the lifespan, support the development of and promote evidence-based treatments to effectively manage pain, and reduce clinically inappropriate prescribing of medications with the potential for misuse. And then you'll see that there are some examples of some of the activities that are tied to each of the different priority areas and objectives in each of those priority areas. So you'll see CDC is working on surveillance and SAMHSA on our strategic prevention framework. CDC is working on updates to the guideline for prescribing opioids, and the FDA is working on safe use of benzodiazepines. In priority area 2, harm reduction, we know that evidence-based and promising harm reduction strategies reduce the risks that are associated with drug use, including overdose and infectious disease transmission. Examples of harm reduction include fentanyl test strips, syringe service programs, and naloxone. Harm reduction also connects people to important health and recovery support services, and supports an environment that challenges community stigma toward people who use drugs. I don't know about you guys, but I've been working in government for a long time, and it's really satisfying to finally see a strategy that calls out harm reduction specifically. We've got 4 objectives in this priority area: advance research and demonstrations on innovative harm reduction approaches, promote evidence-based harm reduction services, including those that are integrated with healthcare delivery, expand sustainable funding strategies for harm reduction services, and finally develop educational materials and programs to reduce stigma. And you'll see some of the examples of activities. NIH and FDA are working on improving fentanyl test strips. CDC and SAMHSA have come together to jointly work on what was CDC's Harm Reduction Technical Assistance Center, and to expand that, actually double it in size, so that it can work with more community-based organizations that are delivering harm reduction services. And part of that is in preparation for the next priority example of an activity, the harm reduction grants. The American Rescue Plan included $30 million for community-based harm reduction grants that we'll be putting forward, so that can work hand in hand with the Harm Reduction Technical Assistance Center. And then CDC has a new Stop Overdose campaign that they are working on. Priority 3 area is around evidence-based treatments for individuals with substance use disorder. It's essential to reduce health and social consequences of substance use. This priority area aims to reduce barriers to accessing effective treatments, advance strategies to support and improve engagement and retention, and to continue to develop new therapeutic approaches. Some of the objectives are to support research on and development of new treatments and strategies to improve engagement and retention in care, broaden access to evidence-based care that it increases willingness to engage in treatment, increase the uptake of evidence-based treatment delivery that improves engagement and retention in care, and promote evidence-based integrated care for people with co-occurring conditions across lines of service and care settings. And you'll see some of the examples of activities like the Healing Communities initiative that NIH and SAMHSA are working on. CMS has its Medicaid Section 1115 SUD demos. CMS is also working on a maternal opioid misuse model. Some of you may have been part of that work over the past couple of years. And CDC has its overdose response strategy. And last but not least priority area, and my favorite priority area, of course, which will come as no surprise to you guys, is recovery support. For many individuals with substance use disorder, we know that treatment alone is insufficient to support long-term recovery. In fact, it's only the start of the engagement process. Recovery support services, as I shared with you in my own personal story, can enhance an individual's outcomes by supplementing treatment and bolstering recovery capital. Examples include supportive housing, recovery workplaces, and peer support services. Some of the objectives include enabling access to and encouraging use of integrated recovery support services, improving the quality of and coordinated recovery support services, strengthening recovery support workforce. We know we need to continue to work on that, and research, to do more research and identify best practices for recovery support services and strategies that are going to sustain those services. And some of the examples we have identified here of activities are our recovery support service grants that SAMHSA has. We have a brand new, well, it's probably a year and a half old now, a peer recovery center of excellence that's helping really build more effective recovery community organizations that can deliver services. HRSA has its paraprofessional education and training program, and CDC has a workplace supported recovery initiative. So how are we going to resource all of this? Well, the President's fiscal year 2022 proposed budget for HHS on overdose prevention programs and initiatives totals $11.2 billion across the department. There's $3.9 billion more in FY21, a 54% increase from FY21 enacted. It includes funding to expand access to substance use prevention, treatment, harm reduction, and recovery support services, as well as funding to bolster the nation's behavioral health infrastructure. I'm going to talk a little bit more about SAMHSA's budget in a minute, but there's $3.5 billion more for the substance abuse prevention and treatment block grant, the set aside for recovery support services, and then HRSA's request includes $1.1 billion in mandatory and discretionary funding to support the substance use disorder response in community health centers, invest in our National Health Service Corps, develop behavioral health workforce, and expand substance use disorder response in rural America. So that is the kind of the top line messaging around the HHS overdose prevention strategy. Where can you find out more information? Well, you can go to the website, of course, HHS.GOV /overdose-prevention. That will give you all of the initiatives. This is where we're going to track all this information that I mentioned. We're going to, be constantly updating this website, but you can see the 4 pillars. You can dive down into each of the pillars and see more about the specific activities. I only mentioned a few, one example per objective here, but you can see all the 44 activities on the website. Again, we'll continue to update this as we go along. So we are going to be monitoring and updating the plan as necessary. We're identifying opportunities for interdepartmental partnerships. This strategy cannot succeed if it's only HHS alone. We need to bring in our sister agencies, DOJ, DOD, the VA, Department of Education, and more. And the overdose prevention strategy will guide future policy development at our agency and across the government. Now let's talk a little bit about SAMHSA's budget. Our regular appropriation at SAMHSA prior to COVID was, you'll see it at the bottom there, $6 billion in 2021. And then because of a variety of COVID relief bills, like the one that's on this slide, we received an increase of $4.25 billion to that budget. And these are the different areas that it went into. 1.65 billion increases in each of the block grants, the Community Mental Health Services block grant, the Substance Abuse Prevention Treatment block grant, gave immediate resources to states and local communities to respond to the crisis at hand. Then in a few months later, the American Rescue Plan passed, which gave an additional $3.56 billion to SAMHSA, another $1.5 billion for each of the block grants, and then additional resources for community-based funding for local substance use disorders. That's the harm reduction grants that I mentioned earlier, and a bunch of other important programs as well. And then in 2022, our budget request is $9.7 billion. So you'll see where some of those increases lie in our FY22 budget request. That is still making its way through Congress, and we are hoping that it gets looked upon favorably by them. We know that this budget process is a complicated one, but we're really pleased to see, that we are getting the resources, finally, additional resources that we need to respond appropriately to the communities that are struggling around the country. These are a list of some of our grants and resources. You can see we have many different grant programs that are really responsible for helping us combat the crisis, and lots of publications and resources that we are constantly publishing, updating, putting out there into the world for all of you to use. We also have, I mentioned the ATTC earlier, and about my story about going to work there. The ATTCs are kind of our flagship training and technical assistance center. We have 20 some other technical assistance centers as well, who are helping us get this information out into the community, helping to train our workforce and really bring people together to learn and try to do things better. I wanted to just touch on a few of SAMHSA specific programs and give you a little bit more information since we have a little bit of time here. Our state opioid response program, the aim of this program is to address the opioid crisis by increasing access to medication-assisted treatment using the FDA-approved medications. It's turned out into a really big program, almost $1.5 billion today that's available for dealing with the opioid response that's happening in 57 jurisdictions around the country. In addition, the SOAR grants now have been expanded to be able to address stimulant misuse and disorders, including cocaine and methamphetamine, which we talked about earlier, has been spiking. There's a sister grant to the SOAR grant called the TOR grant. That's the Tribal Opioid Response Grant, which is doing the same kind of work, but in Native American communities around our country. We have our first responders Comprehensive Addiction Recovery Act grants, which is to allow first responders and members of other key community sectors to administer a drug or device approved or cleared under the Federal Food and Drug Cosmetic Act for emergency reversal. So we're talking about Narcan here. This is the congressional language for it. In SAMHSA's work, first responders are including firefighters, law enforcement officers, paramedics, emergency medical technicians who are getting involved and really helping. Here's a little success story about DuPage County Health Department in Illinois, which is sharing information that the grantee developed a GIS map to show naloxone administration by municipality, substance use treatment providers, drug take-back boxes, and overdose reversals and cause of death from the coroner's office. Philadelphia implemented a new EMS alternative response unit known as the AR2. A paramedic and a case manager ride together in AR2, which is a marked fire department SUV, and they respond when an individual is revived from an opioid overdose. I don't know if anybody was listening to NPR this morning, but there was a NPR story about San Francisco who has a very similar model and are having a lot of success out there with that. Our harm reduction grant programs, I wanted to just mention briefly here. You're going to be seeing this funding opportunity announcement soon. This is to encourage individuals to take the steps to reduce the negative personal and public health impacts of substance use, reduce access barriers for underserved populations, reduce stigma, and increase inclusivity. The purpose is to connect individuals to overdose education, counseling, and referral to treatment for infectious diseases, support distribution of opioid overdose reversal medications, and more. Lots of equipment and supplies can be purchased with these grant dollars. We have our medication-assisted treatment, our MAT-PADOA program, which many of you are aware of, and it's been around for a long time, which aims to expand and enhance access to medication-assisted treatment services. Rutgers University initiated a peer navigators specialist program. As a result of the program, there was a marked instantaneous uptake of dosing and prescribing of buprenorphine by 22%. And Rushford implemented a tricycle, which is an app to connect client, clinician, doctor, and recovery specialists together. Since the inception of the app, over 7,000 interventions have been made, and the program reports there's been no overdose deaths or suicide attempts. And then we have two of our flagship peer recovery support service programs, our RCSP grant program, which has been around for a long time, and our Building Communities of Recovery program. Many of you know about our practice guidelines, which allow any doctor or other practitioner to administer buprenorphine, by exempting them from some of the requirements like education and providing counseling to clients to try to increase the number of docs that are prescribing. Since this was released back in April, we have had 6,300 practitioners take advantage of the exemption. So in theory, we have 6,300 more people prescribing this life-saving medication today than we did back in April. I know many of you are concerned about the COVID flexibilities. There's an urgent need to continue to address the needs of those with opioid use disorder. We're working very closely with the DEA to make sure that people with opioid use disorder continue to get the treatment that they need. We've made it flexible so people can get a greater number of take-home medications, medication pickup and delivery flexibilities around prescribing and dispensing, telehealth flexibilities, and expansion of mid-level practitioner clinical responsibilities. We are working very closely to try to review the data and the evidence about continuing these flexibilities into the future. So stay tuned for more information about that soon. There was a moratorium that has been lifted on mobile methadone units. That moratorium existed for many years, and now it's been lifted, and you can use your SAMHSA grant dollars to get these mobile methadone units up and running again. And then we're looking at contingency management. How can we raise limits and make this evidence-based intervention, especially for stimulant use disorder, more available to people around the country? And those are my slides for today. And I want to thank you again for the opportunity to be able to be with you and to present. And I would love to use the rest of my time to answer any questions folks may have.
Wonderful. Thank you so much, Tom, for a really rich discussion around an introduction to you and to the initiatives that SAMHSA is undertaking, the direction for the country post-COVID, and as we move through this this challenging time. Some exciting new things on the horizon, and the leadership is amazing. Thank you.
Thank you. Thank you, Tracy.
I wanted to make sure that people know that the chat is open for questions, and we do have some time to allow for question and answer. So if you have questions for Tom, please place them into the chat. Reflect them back. One question I had was around, so there's so many amazing initiatives with and especially allowing for and naming harm reduction. It feels like it's been a long time in coming. There are many things that are a long time in coming, but I wanted to get a sense from you, is there, and being all researchers here, is there an appetite for and discussion around research in harm reduction related topics that you're hearing and seeing in directions that might be going?
Absolutely. So, there's addiction, the substance use disorder itself is probably one of the most robust, least robust areas of research that we have right now in medicine. And so the more we can research it, the better, obviously, position we'll be in going forward. And when you kind of look at each of the individual pieces of the strategy, when you look at prevention, treatment, harm reduction, and recovery support, in prevention and treatment, I think we probably have the most robust research, although we need more, but we probably have the least research in harm reduction and recovery support. So from the government's perspective, we're very much looking at trying to increase the amount of research that's happening in both of these spaces. One of the more controversial topics that is part of our generation are these new harm reduction sites or overdose prevention sites, safe consumption facilities that are being talked about around the country. And one of the things that we definitely need to see there is more research as well. So are there opportunities for research in these places where we can ultimately find ways to do this work while at the same time, not making ourselves subject of some type of federal, doing something against one of the federal statutes. And I think we're seeing a lot of conversation that's happening in that space right now.
Exciting.
Our friends in Rhode Island are anxious. They passed a state law to give the Department of Health regulatory authority over these harm reduction centers. And the concern is around federal law now. So how do you do demonstration projects? How do you do pilots? How do you do things where you can be researching these important strategies going forward, and not putting yourself at odds with federal law? So we are working with our friends at the Office of National Drug Control Policy and the Department of Justice to try to find out, exactly what can be done about that. That's it's an area where we know could make a difference. It's made a difference in other parts of the world. Can it make a difference here in our own country?
It's really helpful and very forward thinking, because harm reduction centers are only one of many things that that may be challenged by federal law, but that still may have quite a lot of promise in the areas for public health and public safety. And you can't really simulate. With science, we use a lot of simulation and different models and anticipatory research and intentions, expectations, and willingness and things like this, but it's never the same as, it doesn't always map onto human behavior and social interactions. And
absolutely. And given the fact we are where we are, it looks like we'll unfortunately hit 100,000 overdose deaths in the near future. We have a responsibility to do more and to do everything. As you mentioned, it may not be, it's certainly not the singular thing that we need to do. We need to be doing all these other things as well. And we have to make sure that that singular thing doesn't take us away from doing all the other things, but we should be doing everything we can to save lives.
We have a question from someone in the chat asking about the Peer Navigator program at Rutgers University that looks like maybe was funded through the MAT PDOA. Is there a place where there is more knowledge transfer that we can learn about the Peer Navigator program? Such a popular methodology, and with many opportunities to try out different
Sure, I'm happy to provide contact to the Peer Navigator program so folks can connect and learn more about it and do a little bit of knowledge transfer there. And I'm sure they would love to show off what they're doing. Great.
Well, we can circle back, and Callie and the team, maybe we can circle and send that out. Yeah. There's a question too, asking if you, and thanking you for sharing your story, but when it comes to barriers to prescription, like treatment medications that you mentioned, dissemination of prescription medications, do you think monetary incentives are the biggest motivator for prescribers?
So can you repeat the question once more?
So thinking about how to get medication treatment into the community, and what, I guess this bigger question of what are the biggest motivators for getting prescribers to prescribe more medication treatment?
Okay,
and
I understand.
Monetary incentive, behavioral economics at play, or as a determinant or not.
Well, of course, I mean, it's been used for decades, right? As a motivation. I think, there are some ethics involved with it that we have to be careful of. But I think we are, and there's also, given the large Medicaid population that we have, and Medicaid as a large payer for this, there may be some federal barriers to doing that. So, but I'm happy to take that back and talk with our colleagues at CMS and determine, what barriers, if any, exist, and where they are in terms of advancing this as an incentive for providers to be able to do that. We know that we need some type of incentives, because we are we can just look at the data from waivered prescribers to know how many waivered prescribers we have versus what their patient load is, and we know that there's no shortage of patients out there, that that we really need to be paying attention to that. And how do we incentivize those providers to start actually prescribing if they've been waived? The question I have too is, and I mentioned this in one of my slides, is around treatment engagement, right? Because I think half of it is around incentives for prescribing, but I often say that this isn't Field of Dreams. We don't build it and they will come. We have to do the hard work that's required of engaging somebody in treatment. We have to use evidence-based strategies to bring people around the stages of change first, right? From pre-contemplation to contemplation to action. How do you do that? I think we've seen the impact that these peer navigators have had, peer coaches, recovery community centers, outreach teams in communities who have engaged with people. But even in that NPR story I mentioned this morning from San Francisco, that was one of the points in the story. It's like, okay, we're finding folks, we're providing them harm reduction opportunities, but then when it comes time to engage into treatment, where there's a disconnect. And so what can we do to really train up the outreach workforce on these evidence-based strategies, motivational interviewing, other types of strategies, using incentives, using contingency management, using everything that's in our toolbox to help engage people into treatment? Because then we can bring the patients to the providers, as opposed to having to just. I think if we just incentivize the providers, I don't think it will be enough. I think we have to do both, the engagement and incentive.
And it sounds in some ways like the workforce investments, and really thinking about the many different types of supports, community health workers, peer support recovery specialists, and other professionals and paraprofessionals coming to in many peers coming to the table can help with that, but also maybe some of the contingency management explorations that you and the SAMHSA and other agencies are really looking to understand can help us, give us more tools.
Absolutely. It's a both and, right? So we definitely need the workforce piece, but we also need the tools in the toolbox so that we don't set this workforce up for failure.
You have a question asking about the data to help guide us, and asking for some, if you could shed some light on some of the challenges with our existing opioid surveillance programs, and maybe what more we need.
Oh my God. So I always try to divorce myself from personal opinions versus the official government stand on this. But, it's interesting, and I hear people opine all the time. I'm not opining right now. I'm telling you what I hear other people opine about. I hear other people opine about the COVID pandemic and how every day we have, we could look at a dashboard at any given day, at any given hour, and know how many people tested positive for COVID. We know how many people died of COVID on a daily basis. We hear, you turn on the nightly news, you hear it every single day. Yet our data and our surveillance for overdose, not even fatal overdose. I'm just talking overdose in general, where we could actually intervene right while somebody's still alive, because that's our goal, is to keep people alive as long as we can, so that we can get them the help that they need. If our data and surveillance actually matched what we have with COVID and overdose, where would we be today? I think we'd be at a different place, right? So, yeah, so we have a lot of work to do to get there. COVID is slightly different than overdose. Of course, there are differences, so you can't make that comparison. It's not an apples to apples comparison necessarily. But there's, I think, some truth into how much the government and the public has come together around that public health data versus how much we've come together around SUD public health data. And so our goal at the Department of Health and Human Services is to try to continue to raise that question. We have our Assistant Secretary for Planning and Evaluation, who, that's kind of HHS's data arm. We have robust systems at the CDC for data and surveillance. SAMHSA has we have our flagship NISDA, but that data runs 2 years behind. We just released our 2020 data a couple of weeks ago, and we're at the end of 2021. We're almost in 2022. So that was data that was collected in 2020. So we need to get more up-to-date, current data that can inform the work that's happening on the ground. Now, that being said, that's federal data. Many states have, and local jurisdictions have figured out a way to get better data. We know through initiatives like OD-MAP and the resources of the high-intensity drug trafficking areas. The HIDTA folks have surveillance systems around forfeitures and other kinds of things that can help inform what's happening on the ground. So it's not like we don't have both hands tied behind our back. I mean, we probably have one hand tied behind our back when it comes to data and surveillance. And so we are trying to find ways to up our game in that area. And if the researchers who are on this call have ideas about how to do that, we're all ears. One of the things we rely on local officials in a lot of cases to provide that data. And so it's going to involve it's not like just the federal government can flip a switch and start collecting the data. We rely on the local infrastructure. So it's probably going to require a massive investment in some of the local systems that exist to be able to collect that data. And then again, trying to find, we're at least 3 months behind in overdose death data that we get from states. And then we're an entire year behind when we try to bring together the federal data, because there's with overdose, there's a lot of confirming and reconfirming that takes place. Anyone that's served on an overdose review panel knows that, to try to determine the cause of death, whether it was actually overdose or not, can sometimes be, it can take multi steps, and it's more than, it's not a simple process. So, but we definitely have to do better there.
There's a question. The next question is reminding me that many of our data sources are very closely aligned with law enforcement and require kind of a forensic process, one that is that can be a really tough topic, and can sometimes be at odds with our public health and behavioral health outcomes and goals. But the next question is, so maybe you can speak to that, and maybe can you talk about some of the trends at the federal level under this administration that are, and maybe the previous one as well, toward a more healthcare-based focused drug policy rather than a more criminalized one and criminalizing of addiction. And really, if you can speak to some of the internal obstacles to these sort of shifts in policy and actually in data, I mean, in truth, or can it be shifted?
Right. So, I believe personally that there needs to be a public health and public safety approach to this problem. And, I think both sides have done an amazing job. Like I've seen a real transformation over the last 10 years about how law enforcement has come together and public safety has come together with public health. About the task force in Rhode Island, Tracy, and the efforts there. It's pretty amazing, right? Where we are today versus where we were before. We have things like the HOPE initiative or the PARI program and other types of model programs around the country where law enforcement has said, we know that we cannot arrest our way out of this problem. We have to recover our way out of this problem. And so we need to learn from public health officials, and so I'm seeing the same thing at the federal level. I'm not seeing, if you look at the ONDCP year one priorities, you'll see, it is not a totally supply driven strategy that they have or priorities that they have. They have, it's both supply and demand. That being said, this is the changing nature of this epidemic over the last 5 years, where we've shifted, to entirely illicitly manufactured fentanyl that's killing people. Begs the question of, what more we need to do on the, interdiction side, right? Because the poisonous nature of the substances that are coming into this country, we are not going to be able to solve this with just a public health strategy here on the ground, and trying to work toward, even if we did each of our 4 pillars of our strategy perfectly, we're not going to solve this, because there's such an incentive for, financial incentive and other incentives for these illicitly manufactured drugs that are coming into our country and getting into our streets. We need to be able to have both happening at the same time. And I am sometimes very frustrated and sometimes worn out, thinking that we're going against a tide that's so much stronger than anything we have on the public health side, that I have to do sometimes a reality check and say, yes, this is still important. We're still, the work that we do every day still needs to continue. Of course, I believe that. I believe it, in my heart and in my soul, from my own personal story, and so many of my friends who have found recovery too would, keep me on that path every day. But I'm disheartened by the changing nature of the epidemic and the poisonous, the level of poison in our drug supply that makes it so difficult for us to respond.
Yeah, I was thinking about some of the I think you called it interdepartmental partnerships with Department of Defense and Justice and VA, and kind of thinking that many of those partners are, I mean, not all focused on interdiction and otherwise, but may have a role that implies potentially more criminalization and more other, are there parallel conversations in those organizations happening around how can we think more, wear more public health hats, or think more strategically about?
Yeah.
Please enlighten us. These are the things they can never ask and you never read about. But
yeah, no, absolutely. It's, like I said, it's been amazing to watch kind of the shift that's happened. From when I worked in the federal government in the Obama administration till now, the changes that have happened in terms of the kinds of things we can talk about. The fact that we can talk about harm reduction openly in a government meeting speaks volumes, right, to the level of education that's happened on both the public health side and the public safety side of the House. I think that speaks volumes. But we have a long way to go. I think we still have 15 states where syringe services programs are illegal. We made fentanyl test strips an allowable expense in all SAMHSA grants this year, which was great, right? But you know how many jurisdictions still prohibit them from being distributed in their states? Lots, way too many. And these are places where the epidemic is raging. The crisis is raging. Overdose deaths are on the rise, and they're not willing to engage with the tools that we know work and that save lives. So I think, there's been great education at the federal level. We've educated a lot of the more traditional law enforcement type agencies about the public health approach that we're taking. I think many of them, they're interested, like I said earlier, because they're frustrated too. They're not making any ground. They're losing ground on the criminal justice side of the House. And so they're very interested in the public health piece, and they're trying to incorporate that on a regular basis. And so these interdepartmental work groups and policy councils and strategy sessions that we have with our partners around the government have proven very, very successful. And I can't think of a specific example or story but I'll try to think of something that kind of crystallizes that and makes it real for people. But you can imagine, when we were sitting, I went to a meeting at the White House with acting director of the ONDCP, Regina Lebrel. She brought together, all the agencies in the federal government that have equities in this space. And half of the table was law enforcement. The other half of the table was public health. And, it was an incredible meeting to hear everybody report out on their activities, to hear traditionally law enforcement type agencies report out how they were working with public health agencies in this space. Just gave me a lot of hope.
It's exciting, and research is there to both document, standardize it, and consider some of the impacts and potentially some unintended consequences too. This is a place of growth for the country.
Well, I'm thinking about the conversations just you and I have had about the drug checking research that you've done, and how you have engaged local police departments, who have let you in to their evidence rooms to test samples. And they're, like I said, they're just as frustrated as we are, and they're trying to come up with answers. And I think they're willing to do things that they've never even thought of doing before. So I would say to the folks that are in this meeting today to go where you think you can't go, to pursue the kinds of things that you will be surprised at the level of cooperation I think that you'll encounter. Now, there's going to be places where you're going to encounter a brick wall as well, but there's just going to be just as many, if not more, places where they're going to welcome you in and welcome your help because they are frustrated as well. We can't do this alone.
Well, I know that the communities and research organizations represented here in West Virginia and Nebraska and Rhode Island have been particularly affected by the addiction crisis more broadly, and are excited to be doing research in this area. And we will definitely call upon you for and others and the nationally to try and help us navigate these areas. And I think there was one last question around, unless people would like to post one, but I'd like to ask if you could help us think a little bit to another area you said where it'd be helpful to get additional research is in in recovery, and with the Office of Recovery opening, and as one of the major strategies, I think it would really benefit from hearing a little bit more about, you talked about the workplace recovery and efforts and the building out of the treatment and recovery workforce. Are there places and questions that would help bring more paths forward for SAMHSA and others?
Well, yes, I think so. And, I'll answer, I'll give a little bit of an answer here, but I think this really requires more of a conversation. So if there's an opportunity to bring folks together in the future as we are pulling the Office of Recovery together at SAMHSA, we would love to do that. We'd love to chat with researchers about their ideas about more robust recovery research. This is it's interesting. I talked about the NSDA earlier. I remember like about 10 years ago, I spoke at the Recovery Month press conference where they released the results of the NSDA. And I said, I was a recovery advocate at the time, I wasn't a government official. And I said, we're releasing the NSDA data today, which is interesting because the NSDA tells you basically, like what kind of drug is being used on what street corner in America at what time of the day. And like that's maybe a little bit of an exaggeration, but it has so much information about how people use drugs and what drugs they use and all that kind of information, but it doesn't have any data in it about recovery. Like we don't collect information about like how are people getting well and staying well. Let's start to look at that. And I've been so impressed by folks like John Kelly at the Recovery Research Institute at Harvard, who's made this his life's work, people like Keith Humphreys and others who have gone out of their way to study. There's a whole group of people in recovery who are researchers now who are getting together. And so I think we could bring people together to talk about that and to find out what needs to be studied better. John's doing a whole bunch of research right now in recovery community centers and their impact. I think it would be really interesting to know about some of these other outreach efforts. What works best, how it works best, so that we in the federal government also know like what we should be investing in. So when we're providing technical assistance to Congress about what programs to fund and what programs to authorize, what is going to be the most effective way to help people. So we welcome a longer conversation about that. By the way, I had that conversation at the NSDA press conference, and then when I went to SAMHSA a few years later, as a political appointee, I was able to get myself and Tom Hill and others at the agency, we were able to get a couple of questions in the NSDA about recovery. So now we actually measure at least prevalence of people who are in recovery. We actually ask that question now in NSDA, which is great news. But that's not the level of research we need. We need much more detailed research on this topic. And there's a Surgeon General's report for those folks who don't know. There's a Surgeon General's report on alcohol, drugs, and health that the current Surgeon General, when we was the former Surgeon General, commissioned. SAMHSA was in charge of that project, and we released that in 2016, and that has a whole chapter in it about recovery support, the many pathways to wellness, and there's some call outs for research actually in that chapter.
That's incredibly helpful. And I think for others who might be interested in pursuing research on these four strategic areas, the information that Tom shared in this presentation and the recently released strategy in detail, and some of those resources can help guide the way. And it's nice to have prevalence estimates on some of these topics to sort of get us inspired to advance the research and plan for better studies.
Absolutely. Yeah. You know, that one of the issues with recovery research too is people do identify differently. So, you know, folks like John Kelly and even in our NISDA, you know, we ask questions about problem resolution as opposed to recovery, because you know, some people identify themselves as recovery, like myself. You've heard me talk about myself being a person in long-term recovery, but other people don't talk that way. They, you know, this still remains, you know, a very personal piece for some people. So some people don't look at themselves as being in recovery, although if we heard their story, we would say, oh, you're definitely in, you know, from our definition, you make yourself in recovery. So we've tried to find a way to help people identify, you know, problem resolution as opposed to whether they're in recovery or not in recovery, and what that means for them.
Yeah, no, that's helpful to understand.
Everyone's goal too is not abstinence, right? So sometimes problem resolution does not include abstinence, and I know that's that might be heretical for the recovery community to hear, but we have to really expand our understanding of what problem resolution entails for somebody.
And it kind of brings full circle how harm reduction is very much part of that continuum, and that broader view of SAMHSA's areas for improvement in the country and what we can offer our communities.
Absolutely. And by the way, not to spoil anything, but we're going to be really leaning into harm reduction a lot more. You know, just like in 2010, I believe SAMHSA came out with its definition on recovery, and we did a national convening. We brought together, you know, stakeholders from around the country to define what recovery was. That's where we came up with the 4 dimensions of wellness, you know, the 4 dimensions of recovery: health, home, purpose, and community, and then 10 guiding principles. Wouldn't it be great if we had something like that for harm reduction? Wouldn't it be great if we had a definition we could all agree on, and some major components and guiding principles that the community's actually weighed in on? So we're going to be doing that convening shortly, you know, coming up in the near future, and doing a lot of work to try to lean into this topic more, so that we are, you know, we're not just speaking from a government tongue on it, but that we have the lens of stakeholders from around the country.
That's fantastic. Well, remember your family of researchers at RDAR and the COBRE. And
absolutely, you're on the list. You're on the list.
Otherwise, we'd be very happy to help think about everything.
We need your help.
Excellent. Well, this has been amazing and a very exciting exchange. And thank you for everyone for joining us for this initial session, for your amazing questions and stimulating discussion topics. Just a reminder, we will be having a short break before we start our sessions at 10 o'clock Central, 11 o'clock Eastern. And we'll be looking forward to some additional, some research sharing and additional question and answer and discussion with our speakers throughout the day. But I'm very grateful for you, Tom, for joining us and beginning our amazing symposium.
Thank you, Tracy, and thank you to all the symposium attendees. Have a wonderful event.